Jackie. Thank you all for being here today. Our session is titled Building Capacity for NMDOH Integration Through Research Partnerships. As healthcare systems embrace NMDOH integration, we know it's critical to demonstrate the impact and cost effectiveness of non-clinical initiatives within the clinical space. Collaboration with academic research partners allows healthcare systems to build this necessary capacity to test, learn, and innovate in addressing non-medical needs of patients. Through today's discussion, we'll hear details about current NMDOH research initiatives serving Harris Health patients. Our session is moderated today by Dr. Hope Galvan, the Vice President of Population Health at Harris Health, where for more than 16 years, her work has been defined as an unwavering commitment to optimizing healthcare delivery systems and driving care transformation for patients in her community. Please join me in welcoming Dr. Galvan.
Thank you, Charles, and good morning, everyone, and welcome. It's truly a privilege to be here today to introduce our 4 remarkable women who are breaking barriers, challenging norms, and blazing trails in their respective fields. So thank you for joining us. So I'll start by introducing Dr. Maninder Mini Kalan, founder of Factor Health at Dell Medical School, also associate professor in population health at Dell Medical School and director. Thank you, Mini, for being here today. I will move on over to Dr. Shrila Sharma, professor of epidemiology, founding director of the Center for Health Equity at UTHealth, Houston School of Public Health. Dr. Sharma has a research interest in food and nutrition security and co-occurring SDOH, social determinants of health, system science, and health equity, and has a robust federally funded research program in this area. So thank you, Dr. Sharma, for joining us today. Dr. Vanessa Schick, who's an associate professor of management, policy, and community health, UTHealth, Houston School of Public Health. Dr. Schick has a research focus on the needs of vulnerable and underserved populations, including those who have experiences with homelessness and criminal justice systems. And last but not least, my colleague, Denise LaRue, who is an administrative director in clinical integration and transformation here at Harris Health. And her work focuses on building capacity for health equity through initiatives that optimize Harris Health's ability to focus on disparities, as well as to assess and address health-related social needs within system processes and workflows. So thank you, Denise, and thank you everyone for joining us today. And I'm gonna hand it on over to my partner, Denise LaRue.
Just to jump in quickly, Dr. Kalen's computer crashed. I just got a message. She'll be rejoining and will join us in a moment. Sorry, continue.
Thanks so much, Jackie. If we could get the slides up, I am going to walk you all through just to set the context a little bit for Harris Health, our journey, and kind of tee us up for this conversation about partnerships. Thank you so much. We're seeing, just so you know, we're seeing the one that has like the comments on it if you want to, yeah. Perfect, thank you. If you can move on to the next slide. Perfect, thank you so much. All right, so again, I've worked at Harris Health for approximately 16 years. I am proud to have grown up here and been here since the population health department started. I wanted to start this conversation just setting the context about who Harris Health is within our community. I'm sure we have some folks joining from either outside of the area or perhaps even outside of the state. So I think it's really important to set the stage about who we are and who we serve. So Harris Health is a safety net system for Harris County. That's where Houston, Texas is. And we've been doing this since 1965. So we are the county safety net serving all of Houston and Harris County. We do things big here in Texas. So we're the 3rd most populous county. And unfortunately, a #1 spot that we hold is that we're also the highest uninsured rate in the country. And so those are really important factors to think about as we think about how do we actually successfully do NMDOH work given our situation. Harris Health is a comprehensive and fully integrated system. We have 2 hospitals. You can kind of see here this map that has our footprint across the county. We have, close to, between 18 and 20 community health centers. We have homeless clinics, dialysis centers, specialty HIV care centers, dental centers. So we really are doing quite a bit to serve the needs of this very needy community. Next slide, please. So again, to set the context, who are we serving? So I've mentioned that we're serving, Harris County is the seat of the highest uninsured rate in the country. And when you think about the patients that we're actually serving, that's really important as we think about, how do we take on new work, right? And so, we always have to think about, how do we, convince leadership, convince, we're using taxpayer dollars. How do we think very strategically about doing new, novel, and innovative work? If you look on the left, nearly half of our patients are uninsured. So those are patients, we're a non-Medicaid expansion state. These are patients who are who do not have the benefit of Medicaid, and so we offer a financial assistance program or charity care program to help support those needs. And you can see kind of like the other cuts across payers. And also important to know is that we're serving a majority minority population. It's not a minority here in Houston, Texas, but nearly 86% of our patients are racial or ethnic minorities. So when you think about those co-occurring poor health outcomes, co-occurring rates of poverty, of social needs, it really is a needy population who we're serving. Next slide, please. So I want to talk a little bit just about Harris Health's journey in NMDOH. Our population health department started back in 2017. We had started dabbling in some screening. And so, really over the last few years, these are kind of like the buckets of work that we've really been seeking to deepen. So certainly, just awareness across our organization, not just to patients, but also to staff itself about like the importance, the impact of non-medical drivers of health and how we as a system are really changing and adapting to integrate those considerations into the way that we provide care. So we've done some of that through launching our We Ask Because We Care campaign, letting people know, hey, not just patients, but staff, we're going to be asking questions about your social needs, about your food insecurity, about your housing. And this is why. It's all for the purpose of advancing health to improve outcomes. We're doing a lot of work in the space of screening patients for health-related social needs and trying to connect them to community resources. Harris Health participated in the CMS Accountable Health Communities pilot initiative. We have worked really extensively over the last few years to embed those workflows in our ambulatory care space, as well as in the inpatient space, recently kind of like pushed along through the CMS mandate. And we also have some special populations that we're screening, such as our OB populations and our oncology populations, patients that we know are particularly vulnerable. And we're doing a lot of work in terms of like, how do we best connect patients, both to community resources, how do we think about integrating resources within our walls? So a lot of work in that space. Of course, research, which is what this conversation is about today, and I'll go deeper here, but we really want to be able to test, this is still fairly new work. We also want to be able to make sure that we are, doing work that's effective, but also having the space and the ability to test novel interventions that are strategically important to the organization. We want to use the data that we're collecting in terms of, like, for example, screening data, to really be able to catalyze that information for population level insights to advance our health equity efforts. And then, of course, we do believe that as healthcare, our role is to also just kind of like elevate this, like drive that connection between non-medical drivers and health outcomes, and really also serve as a voice to support, this type of work on a larger scale. So with all that, today we really want to, I think if you click it, it'll make a little box on research. Jackie, we really want to focus our on our research partnerships and how we view this not only as an important way to advance and contribute to NMDOH science overall, but how we within our organization continue to make the case to continue to integrate this type of work within our organization. And really importantly, to build the evidence to support payment of this type of initiatives, for sustainability. So I'm really excited to share the stage with these great researchers and friends. Each of them will provide a brief overview of the research initiative that we're partnering on. So you all can have a sense of the types of projects and populations that we really came together around. Each of them carefully chosen and really thoughtfully designed with an eye towards sustainability. So with that, I will hand it over to Dr. Vanessa Schick.
Good morning, everyone. I am so delighted to be able to be here in order and to co-present with this group and this wonderful audience who I get to see in the chat. If you wouldn't mind moving on to the next, there we go. Sorry, I was just waiting for that. I have the opportunity today to talk about a program which we call Project HALT. HALT stands for Homelessness Diversion, Assess the Situation, Leverage Resources, and Transition to Stabilization. Project HALT is an NIMHD funded clinical trial where we're really focused on enhancing the science of homelessness diversion. So this is not for individuals who are actively experiencing homelessness or houselessness. This is really trying to enhance the science of how do we get upstream? How do we prevent people who are at risk of losing their housing from ever experiencing homelessness? We are also focused on trying to understand how to integrate homelessness diversion into clinical care. And in doing that, we have this fantastic partnership with Harris Health. Project HALT is a clinical trial, and the way that it works is we receive the contact information for individuals who are Harris Health patients after they exit the emergency department from Ben Taub or LBJ. Once we receive the contact information for those patients, our team, we have about 10 community health liaisons who work mornings, evenings, nights, weekends. They reach out to every single person. We try to touch them at least 5 times between texts and calls to invite them to participate in this trial if they're interested. Individuals are enrolled if they meet a few eligibility criteria. So we're focused on uninsured Medicare and Medicaid patients, and they have to be 18 or older, and they have to indicate that they're currently housing insecure. If they indicate that they meet all 3 of those criteria, they're invited to participate. We consent them. And from there, our team moves into kind of a 20-minute baseline assessment to better understand their housing and healthcare needs. At the end of that baseline assessment, that individual is randomized to receive either kind of traditional standard resources, which is still kind of a slightly enhanced standard of care, or our homelessness diversion intervention. Our homelessness diversion intervention is designed to reflect homelessness diversion programs across the country. It is a relatively light touch. The idea is to be able to provide the service to as many people as possible. It is designed based upon problem-solving therapy. So the idea is that our CHLs talk to the participants, really explore opportunities to maintain their housing that they currently have in their life, and then talk through potential local resources that they can connect them to. They are also able to join calls with that individual for any difficult conversations that they might need to have, whether it's family members, landlords, or even connecting them to other community. At the end of that call, they'll connect them to community resources and then can follow up 2 to 3 times. Following that, we have a quick evaluation, and then our team follows up with those participants every month. And we've had pretty good follow-up rates. We've enrolled over 700 individuals. I think we've followed up with them about 85% of those individuals at least once. We follow up with them every single month to check in on their housing and their healthcare. At the end of 6 months, we complete an exit survey to explore their housing, their healthcare, their ED use, in order to, again, kind of enhance the science and really understand whether or not this homelessness diversion intervention worked, and most importantly, whom it worked for. So really excited to answer more questions in the future, but that's kind of the 2-minute, if I was able to make it, version of Project HALT.
Okay, well, I guess Denise, am I going next? I'm going next. Hi, everyone. I'm Shrila Sharma. Very excited to be here. I'm a professor of epidemiology and director of Center for Health Equity, which is a research center at the same place Vanessa is at, UTHealth Houston School of Public Health. And I just want to say that while I'm here sharing about our work, it's really want to also acknowledge the team that's behind it and works hard every single day across all of the 4 organizations that you see here on the left. So at the Center for Health Equity, just a really quick, we do a lot of work around social and structural drivers of health. And so we have work around food as medicine, of course, which I'll talk about in a minute, and then also other spaces like medical legal partnership, also more recently around water security, and also physical inactivity as well. So we've added the QR code here if you want to learn more. In regards to the partnership with Harris Health, we've really been fortunate to enjoy a partnership since 2017, I believe, where we actually started working with Harris Health on a culinary medicine-based approach to dovetail with the produce prescription program. And at our School of Public Health, we house a teaching kitchen, and I'm a dietitian. We also have other dietitians trained in culinary medicine who actually train dietitians as well as other healthcare providers in culinary medicine, and also implement culinary medicine in the community. And what we did with Harris Health to kick off the partnership was really do a system-wide capacity building around culinary medicine. We trained all of the dietitians at Harris Health in culinary medicine, and that was very intentional because the goal was to not just start this work around food prescriptions, but really to carry the work across the system. And so keeping that bigger picture and vision in mind, that's sort of how our partnership began. And then we have done work with their adult patients with diabetes. And then more recently, what you see here on this screen is really working with their high-risk pregnant moms who are on Medicaid. And this is a partnership between Harris Health and also other nonprofits. So you see Brighter Bites and Planet Harvest here, and the Center for Health Equity. And our role has primarily been in designing. We do have content expertise in designing food as medicine interventions. It's not a one-shoe-fits-all. So really thinking about what are the needs of high-risk pregnant moms, and working with the Harris Health team and designing this approach, and then bringing the right partners at the table on who can deliver on this design. And we use very much what's called a human-centered design approach to ensure that our patients' lived experience is driving this work as well. And we are in the thick of this work at the moment. We worked with a couple hundred moms who are part of this study, and you can see on the right the outcomes that we're looking at. There's a lot to be done in this space, and one of the main pieces that we're looking at are implementation outcomes, because in the food as medicine space, there's a lot we don't know about dosage, about utilization of what's going home, who's eating what's being given. And so we are tracking that, and then we're also looking at other health-related outcomes and also the budget impact of this program to inform future work in this space. So I'm happy to share more, but I'll stop there and turn it over to Dr. Kalon.
All right. This is such a great group, and I'm looking forward to the discussion. So let's see if I can do my piece in 2 minutes. That was the challenge my colleagues gave me, gave each one of us, I guess. So we are a little bit different than the other two faculty members that have talked. I'm based in Austin, so not based in Houston. And I think that that played a role in the way this particular partnership played out. So I would say that the two things I want to talk about is first where we started for our kidney health program. We'll get into the detail of it. There's a lot of small little letters, so we can maybe just focus on what I'm saying for now and look at the slides later. So the first is where we started and when we started. And so we are really interested in our lab. Factor Health Labs is a translational lab where we really want to change the healthcare system to pay for what matters. And so if we want to change the healthcare system to pay for what matters, as we looked at non-medical programs that could be delivered directly to people in the cadence of their lives, we knew we had to talk to the people who held the dollars and ask them what it is they wanted help with, and also what determines success. And if we started there and worked backwards, we would have a greater chance of eventually moving the system to pay for what matters. And so to make a long story short, we worked with Harris Health. I think starting in 2019, the conversation started. It took 1 to 2 years actually to finally land on what it is they wanted to do that made sense to them, that also we assessed and thought, yes, we could actually make a difference. And so this was an early stage kidney disease. And the way that happened was that our colleagues at Harris Health, they worked with their own physician and other leadership at Harris Health, and they vetted a lot of ideas. And this is now, as you've already heard, Harris Health is a system that's pretty sophisticated in thinking about food for health, but also other non-medical drivers for health. And so when you have a sophisticated system like Harris Health, it's not an easy, like, oh, we don't do anything, so anything works. It's sort of like, what is it that we really need help with where your expertise could work? And so in the end, they ended up really connecting us with some of the physicians that led the dialysis centers. And those physicians were very clear. And they said, please stop this flow of people that are needing dialysis. Let's go upstream. And so I'd actually use Vanessa's language. I love the idea of diversion, right? So we have sort of homelessness diversion. In this case, this was kind of a dialysis or end-stage renal disease diversion. And so we actually looked several stages before most people look at when they look at the impact of food on kidney health. And so we look at kidney health stages, stages 2 and 3, which is kind of when it's a bit hidden, but as soon as people move on to stage 4, that's when it can be really devastating. So that was where we started. So that's one thing I wanted to talk about. And then the second is the nature of the intervention. So because we want people to pay for if something works, we're really focused on maximizing the impact. And when you focus on maximizing impact, the interventions look different than if you start with a focus on figuring out the contribution of various factors. So the contribution of various factors is a more traditional research approach, but because we want to maximize impact, and to impact kidney health, you need to increase consumption of fruits and vegetables by a large amount, by more than a cup a day. And the best that we've done generally goes from like a quarter cup to, if you're really lucky, a half a cup a day. Increase in fruits and vegetables. And so we've integrated multiple aspects into our program. We have in sort of this person-centered way, in the same way that Sheila was talking about, where we integrate direct delivery to encourage taste and trying. We include flexible resources to provide agency and sort of control by people themselves. So these are grocery store cards. We give options on what grocery stores they can use. And then we tie it all together with a human backing, somebody who checks in and is able to continue to provide support in a variety of ways during the course of this intervention. It's a 6-month intervention. There's also some new science that we're doing. Fortunately, we have a great collaborator in Dr. Don Wesson, who's done some great work in Dallas and in Lubbock, and we brought him with us to Houston. and where we are looking at shorter-term measures of improving kidney health, specifically measures that you can look at in urine as opposed to the longer-changing eGFR. We can talk more about that later. But I think those are probably the two most important things to give you a little bit of a teaser of what we're doing with our fantastic partners at Harris Health.
Wonderful. Thank you so much. This has been great. It sounds like research partnerships with intent and impactful. So I'm going to start with the questions, and I hope you all are okay, but I'm going to put Srila, Minnie, and Vanessa first, and then we'll move over to Denise. But I'd like to explore the different ways in which non-medical drivers of health partnerships between academics and healthcare organizations, how they're beneficial to both parties, right? Each of you is representing an academic partner with a focused approach around non-medical drivers research. But why should health systems partner with academic institutions for these efforts? And how is it beneficial to your organization? And again, Srila, Minnie, Vanessa?
Sure. Great question. So, I think there has to be a common, it has to make sense from a value proposition for both entities, right, to have a fruitful partnership. And of course, that starts with a lot of strategic conversations. But using the example of food as medicine and our conversations, right, over several years, from our space, we really want to build the evidence base for food as medicine so that it can be a covered medical benefit, right? And that was a common value proposition because that's what you were interested in as well for the patient populations, especially that y'all are serving. And the other piece was the strategic alignment between your organization prioritizing produce prescription and really having one of the most integrated food as medicine approaches that I've seen in the country. You have co-located food pantries inside your hospitals and clinics, which is a very visual and statement as well as an expensive investment, right, to make for health systems. And so you want to make sure that the resources are not only being utilized, but also having an impact. And from our perspective, that really aligned with our interest in regards to building out the evidence base and doing the research. The other common alignment we have is on really building out the education and the workforce capacity building, right? And so that's the work also that we've done along the way with, dietitians and other, students and public health community health workers, for example, which have been such an integral part of the work that we've been doing. So I think to me, the beauty of our partnership has met the needs of both organizations, and having that constant communication, even when we disagree, right? Making sure that we're having the space to disagree and work through things and arrive at because I think that disagreement has also helped us arrive at a space that aligns with each other's needs as well. So, and I'll stop there.
Yeah, Minnie or Vanessa?
Yeah, I can add, yes to all of it. And I think what I can probably add is we're a little bit more in in your business. So I would start with there, but which is but in a I think in an agreed upon way. So not a little bit more in your business and you don't want that, because what I mean by that is because we're really focused on that translational piece, like let's get the payment system to change. It meant that as we worked so our strengths are in doing research, but in also bringing some thinking around what, looking at the evidence around what actually changes systems to pay for things they weren't paying for before. How do you measure economic impact, not theoretically, but in the language that a system might actually sit up, poke their ears and go, we do something about it. So that happens to be our expertise in our labs at Dell Med. And so what I mean by saying we were more in their business is together we were more in maybe in each other's business. it meant Harris Health is also a system that pays for the care for the uninsured, right? So there is sort of an interest on that end. And then you have a population health group that was being set up when we came that is trying to develop the evidence base in the way Srila meant. So it was actually, I think, and Hope and Denise can share more about this. We played also, I think, a really important role as a kind of a broker, right? Between two parts of the organization that were supposed to be talking to each other and are, but it helped when there was a third party coming in and saying, you know, what Hope and Denise are working on really does, not just at a panel conversation, but really does could impact your bottom line, and let us share how. So we've had conversations on the financial side of the house, from the leadership down, as well as with our partners in population health. And so I think one of the places where our alignment showed up is in bridging the world of evidence generation and trying new programs that Harris Health was very strong at, again, to go back to what Srila was saying, but to bridge that with some of the kind of real world dynamics of large organizations where the financial arm is here, right? And the innovation arm is here. That happens all the time. And so I think that was perhaps different. And honestly, we could only do that because Harris Health was already very sophisticated in how, firstly, in having a population health group, and secondly, in themselves having started programs such as the pantries at the, you don't call them pantries. What do you call them at the clinics?
Food pharmacies.
The food pharmacies, right, at the clinic. So we're way ahead of the game. And so that's what allowed us to come in and be a broker.
Very good. Thank you. Vanessa, anything to add?
Not much. I think that I agree with and appreciate everything that they've said. I guess just two quick things, just to kind of underscore what they've already said is, I think in the development of these partnerships, it really starts with maybe a conversation about, and an honest and sometimes hard conversation about goals and gaps. So what are the goals that both parties have? Like, what are you hoping to get out of this? And where are your gaps that the other person can, or the other organization can help fill in? And I think if you start in that really honest place about what are we all hoping to get out of it, what do we have, what can we bring to the table, what are we missing, I think that helps set you up in order to develop a longer term partnership. I think the other thing that we're kind of all hinting at, but maybe, I don't know, maybe have explicitly said, but is money, right? Like, we all want to do these things, but we need funding to do it. And so I think sometimes, not always, but research partnerships bring in additional funding opportunities, right? So I think with Project HALT, one of the exciting things for us was that we were able to apply for and get NIH funding, which allowed us to hire a team and do work that I think Harris Health would have wanted to do, would be well situated to do, regardless of whether we were there. But having that extra funding to support that work allowed us to do it, and then also allowed us to investigate whether it worked and whether there was economic value in order to make it sustainable for us to continue to invest in it.
Yeah.
Can I just add?
Very true.
Sorry, just want to add one quick thing to what Vanessa said, which is great. But the other, extending the funding piece, I think, some of all of this work, also the common alignment was that Harris Health was also interested in advocacy. I think, Denise, that was one of your boxes. And so that's something that, we enjoyed as well, right? For example, American Heart Association has funded our food as medicine work and high-risk pregnant moms. And that has allowed us to kind of take the work that we're doing and share it from local to national to inform, this work that's happening in all of the other spaces around the country as well. So I think those funding partnerships can also allow for broader advocacy of this work nationally as well.
That's spot on. Yeah, I'm going to move the questions a little bit for the sake of time, and I'm sure the audience has lots of questions. But and what I really love about this team is that we work in a very practical, and in what we do. So we're going to move to the recommendations and practical considerations around this work, right? So I would ask, what advice would you give to someone who's interested in partnering with a healthcare organization about this work? What is one piece of advice? And Denise, maybe we'll start with you about from the healthcare lens, who's interested in this with an academic partner, and then we'll go from there.
Yeah, one thing that I will say that I have truly appreciated, and I think everybody has alluded to, is kind of like that conversation up front about, what's realistic, what's valuable, because one thing that I have valued from each one of these partnerships is the pragmatism that they have, I'll come with, we are, we're a very busy healthcare system that's delivering care for very needy people, and we can't offer a pristine controlled lab environment for doing research, right? And so we really have to think about how does implementing this project affect operations, even, things as, everything from, gathering consent to, Minnie will talk about this, maybe about space, to collect measurements or to do interventions and all of those different things. And so with each of them, I think that, for example, Vanessa's project was really able to leverage some learnings from our Accountable Health Communities pilot, and said, that was a pretty non-intrusive way of learning and testing. And so let's pick that up. Let's continue to do it that way. With Shrila, we meet periodically with our maternal service line, and even with Minnie's project, we have physician champions that are involved who are very vocal and very active about this is the way that we would identify those patients. We don't have this in the chart, so we need to think about a different way to kind of recruit patients. So that very kind of honest and pragmatic approach, I think, is super important. And then from internally, just making sure that we're having conversations with our leadership to understand the benefit of partnering in this space, that, we can't and shouldn't do it all alone, and that there are fantastic experts out here, each of these, experts in a particular NMDOH domain or thinking about payment models and systems change that really kind of help us advance that work. So not doing it in a silo, even within your own organization, really trying to share the benefits of these partnerships internally.
Right. Team, any advice from your perspective? Shrila, Minnie, Vanessa?
I'll just say that yes to everything Denise said, but also, you noticed in Sheila, Vanessa, and in my conversation, there are huge networks of partners at play in these projects. And there is an art and craft to bringing people together to implement projects. And so the first thing I would say is make sure that you or somebody you bring in has done that kind of partnering, that complex partnering before. The work is hard enough, so you don't want to learn about that aspect while you're also trying to do the work. The other thing I would say is, I think you've heard it mentioned from Denise, but getting clinical champions in your system is really important, even if they're not the final decision makers. And so for us, it's Dr. Robbie Wesley, Dr. Jaime Rueda, have been fantastic in, as Denise mentioned, in advocating, but also the on the ground, knowing what's happening with patients, even though our intervention is non-medical. And so I think that's been really key. And for us, as an example, I don't know how many of you are outside, considering implementing things not in the city that you're based. So for us, building out the base of people that we could rely on and they were part of our team in Houston, since we're in Austin, was key. And I would say, Denise is on the team. She's not just like a partner. She has to be. There's no way, especially since we're in Austin. And then Jada Nguyen is in Houston, hired through Baylor. And, our other physicians are from UTHealth. We have Harris Health. I mean, it is crazy. And then Dawn is in Dallas, not even affiliated. And UT Austin had never partnered with any of that Houston organization. So we had to create the first IRB reliance structure for us, which we did not predict. So just to give you a sense of the complexity, which is not to scare you away from it, just to say, just prepare for it. And then as all the different pieces come up, you're ready. You're like, oh, that's another part of the complex web that we have to put together.
Wonderful, wonderful. Just one last question, just for everyone, anyone who wants to take this. Let's talk about the future. What are your hopes or your vision for continued healthcare and research partnerships, or for these particular partnerships?
I can jump in. We are very laser focused on building the evidence base around food as medicine, so healthy food can be a covered medical benefit. And so we are happy to explore partnerships in that space, and happy to offer our expertise. I'll use my mic to also add, something Minnie said earlier, that it takes a village, right, to make this type of work happen. And one of the things that academic institutions also have that we've been able to draw upon is really even though there might be 3 investigators on one team, we can really draw upon the expertise available in the whole school and across all of our campuses as needed, and also our student power, who are very excited and enthusiastic about doing this type of work. And so I just want to put that out there as well for folks as they're thinking about research partnerships in this space.
Wonderful, thank you, thank you. Well, Charles, I will hand it on over to you.
Thank you so much. That was really impactful. You make it sound pretty easy, but acknowledge, there's some bridges to cross in forming partnerships. So I appreciate, the nuance that you gave on kind of the constraints of, the academic institutions and the hospitals. One of those constraints that we often talk about in the webinars is how to fund the services, like the practical services for the patients. But in this case, I think an interesting idea is just how we fund the researchers' time, because for those who are in academic institutions, you've always got to make sure you've got your coverage for the time that you're dedicating to those things. And lots of research coverage is, more knowledge generation and abstract, I guess, than what you presented here, which was super practical and feeds immediately back into the system. So for the practitioners in the audience, what should they understand about how you have to find that funding, or how to get the kind of coverage that's so practical?
I mean, I can chime in from the funding side of things. We've generally used the philosophy of, I know there's a question there about like continued funding, which is a different, important question as well. But when it comes to doing research and evaluation, we write the grants and get the funding that's needed to do this work. And we work with our health system partners to build those budgets together, because the work of research doesn't just happen in the academic institution. The health systems and community, or all the partners are working actively in this space. So you want to make sure you're building out the funding that supports the whole ecosystem. But we are happy to write grants and partner in soliciting funding as needed as well. In terms of continued funding, which I think is really important, I think you want to start something the way you want to end it, like where you want to end. And so keeping that, I think it's important to have those discussions as an ongoing conversation with your partners as you're building this work on what does continued funding look like, whether there's, internal, supports coming in from the health system partners to continue this work, or community organizations as well, that can continue to fund this type of work, or is it philanthropy or other grants, or hopefully reimbursement. So I think that has to be a conversation right from the beginning as well, for food security doesn't just go away because the grant ended.
Yeah, and then I'll bring a little bit of realism from the academic medicine side. So Vanessa and Sheila are at School of Public Health. I'm in a academic medical center. And I'll tell you, it's not rosy. So we were very fortunate to get funding from the Episcopal Health Foundation, but incentives at academic medical centers, including ours, are to, if you were just a faculty member, I have a very varied existence, but if my success were tied to being a faculty member, I wouldn't do this work. I couldn't, because I am being judged on NIH grants that are primarily not funding this kind of work. Our incentives are not aligned with impactful work like this translational work in sort of the social determinants of health or the non-medical drivers of health work. So I think this is not we don't have a lot of time here, but I do want to acknowledge that aligning, that especially from an academic medical center side, aligning incentives for faculty with this kind of work is unbelievably important and does not happen as a default, including, to do the complex partnering. We have sophisticated people like Nicole Clark, who's here in the audience, Courtney Mulligan. These are all people that perform a range of critical roles. The function of program managers and really sophisticated staff is not well understood in an academic medical center, because lab-based research doesn't require that kind of sophisticated role that is a staff role, very expert, but is not a faculty role. And so we don't have systems set up to really honor or reward those kinds of roles too. So this is the challenging side of things. I figured, we should get raw and real here.
I appreciate you elevating that. And I'm aware of those challenges with alignment. I think all of you are champions and have a passion for this work, but in some cases, the system that you're in can make it, add some extra steps sometimes, or make it additional hurdles. Vanessa was talking about you have to start these conversations with some honest and hard discussions about expectations and goals and gaps. And I wonder, that's kind of at the front end of getting alignment. But then as you move forward, what's like some next hurdles that tend to come up as you're starting projects that are partnerships?
Yeah, I think that's a great question, right? It's one thing it's great to get a project started. It's even more important to continue to invest in and build trust over time. And so I think, again, it's about understanding what one another needs. What is like the level of communication that's right for both parties? What level of detail do you want and data do you need? What is the ask from both sides? And are we both fulfilling what we said that we were going to do, right? So I think just like any friendship or partnership that you have, right? It's like it's being really intentional about making sure both parties' needs are continuously being met. And that might look really different for each partner. So even on Project HALT, we have a few different partners. Harris Health is kind of our primary, right? And they like to be, involved. We, we really consider them, really a primary partner. We provide data whenever they want or need it. They're there to support us as well when we have questions or we have issues. Denise is like responds in 2 seconds. And then there's others who are interested in the outcomes, but have too much on their plate and really, and don't want that constant dialogue, but are there if you need them. So I think it's just, like I said, like any relationship, just understanding what one wants and what needs and being responsive consistently over time.
Great, thank you. Please continue to drop your questions in the chat. And I see one from Christine Vo. Christine, do you want to just unmute and ask your question so I understand what kind of institutions that you're asking about?
Yeah, thank you. My name is Christine Vo, and my question is about the different opportunities that may exist for smaller institutions or like smaller colleges, smaller universities that are in rural areas, and what they can do for future partnerships.
I can take a stab at that. So actually, that's a great question. And we are actually working right now with Tarleton University to support them in responding to a HRSA grant application. And we're providing more of like technical assistance kind of support to help build their capacity to respond to these RFPs that are coming down, and also providing them, if it gets funded, you know, the information knowledge base that they may need to jumpstart these efforts. So because they have the partnerships in the rural, that's rural health is what they're focused on, or at least the faculty member we are working with. And so it's just that we're providing the sort of the expertise we have garnered over time, or the learnings we've garnered over time, and providing the resources that they may need. So that's another way that, you know, I think academic institutions like ours can support some of the, I wouldn't say smaller, but more like ignite this work in different parts and share our learnings. I think that's an important opportunity that we have here.
Yeah, and I'd just add, Sheila's a great example of like a group to go to, because they are, if you're interested in food as medicine, not just Sheila, but the Center for Health Equity, I mean, there's a momentum there. And so the one advice I would give is, especially if you're a smaller institution, be you a community-based organization or a college, make sure that if you're seeking a partnership, the partner already wants what you think you are offering or want to do. And they sometimes won't tell you straight away, but you can pick it up. Don't waste time. If they're not already wanting something, it's like when you go fundraising, right? When you go fundraising, you're not actually convincing someone to give you money. You are looking for the person or the group that already wants to give you money. And if you go to anything less than that, you will waste a lot of your time. And it'll never be satisfactory. So find sort of where the momentum is and where the interests are already aligned and where there's already movement, and then kind of add on to that, start, you know, add on to that, join that, and that's probably most effective.
Yeah, and I was just going to add that, you know, particularly in rural areas, I'm sure we're in a big, you know, quote unquote resource rich area, and this work is very hard. So I can imagine that your healthcare systems, clinics, hospitals in rural areas are really struggling to do this work and could use all the help that they can get. And so to Minnie's point, you know, really connecting early on in the journey to think about how can you create mutual benefit. That would be key.
And can I just add to Minnie's point about making sure that that the potential partner actually wants and needs what it is that you're offering. You know, I think as academics, something that we sometimes do is we think we have this great idea, and we go to the partners and we say, this is a great thing, you need to do it. And it might be great for us, right? But that doesn't mean that they have any interest or that they have the capacity, right? And I think one way of getting around that, beyond, in addition to listening and not continuing to push when they say it's not a fit, is just getting involved with those organizations, right? If there's board opportunities, committees that you can sit on, and just learn and listen. What are their needs? What do they want? And then instead of bringing your project to them, listening to what project it is that they're needing, and then building something off of that.
I just want to add something really quick, is that we learned, you know, we are a safety net. And yes, we are in a large healthcare system, but we don't have a large research department. So I don't want folks to forget that it does take a village, right? And what we learned in collaboration with, for instance, Srila and the Health Equity Collective, is that we had to get out of our hospitals and our clinics and our offices to go out into the community and really connect and start learning what each organization or foundation or what have you, what their strategic plan says, what they're looking for in alignment with what everyone else is saying. But I think as a healthcare organization, we were trying to do this on our own for so many years that, you know, with the change of leadership that said, no, like you've got to go and talk to your community, partner with your community, and that's how you're going to be able to advance some of this work. Because we also don't have, I mean, we're always in a budget crisis as a safety net, right? But a collaboration and a partnership, and it does take a village to get this work done, is really important.
Well, I appreciate all these perspectives. It's clear that partnerships really allow us to accomplish much more than we could do individually, but at the same time, they're very relational, and it requires work to make it successful. So I appreciate you being really candid about what that involves. I'm really grateful for your presentation here. Well, keeping an eye on the time, I'm going to turn it over to Jackie to close us out.
Thanks, Charles, and thanks to our panelists for this great discussion. These types of convenings are critical to advance the NMDOH work by hearing from those who have done it so well. Before we wrap up, I want to invite all health organizations on this call to be a part of a growing opportunity in our NMDOH program index. For those of you serving patients at healthcare organizations, smaller healthcare organizations included, we want to hear how you're meeting your patients' non-medical needs through non-medical interventions. We are looking for health systems, hospitals, clinics, and health plans for this opportunity to showcase the various ways that healthcare organizations are already addressing patients' non-medical needs in Texas. The index is a resource for providers to learn who is doing what for which patient populations. It can also be a resource for policymakers to see how the healthcare system is meeting patient non-medical needs and make policy change in favor of the sustainable payment pathways we keep talking about. The program index will be as robust as we make it, and I look forward to hearing from each of you. The link to the program index is in the chat, so please click on this link and bookmark it when you can add your information. And if you want to reach out to me directly at jk90@rice.edu, I look forward to connecting with each of you. Thank you so much for taking the time to join us today. I will be sharing around the materials in the coming days. If you think of any future webinar topics, we are encouraging you to tell us what you'd like to hear about, and we can go find some people to share that knowledge. Thanks so much and have a wonderful day.
Thanks, everybody.
Thank you.